Absolutely, yes. I'll talk a little bit about the equipment needs and things as well. Excellent. So that's full screen now. So I'll just jump to this slide. So to understand what superior sinus venosus defect, I have included, you can see my mouse. So this is actually a model made from a CT of a patient who ended up having transcatheter treatment. And superior sinus venosus defect is a deficiency in this very upper part of the atrial septum, lower part of the SVC. So to orient yourselves, this is the superior vena cava. This is the right atrium. And in the top part of the right atrium towards superior vena caval junction, there is a deficiency. So behind us here is the left atrium. And this deficiency always occurs at the junction where the pulmonary veins are joining or trying to go and join the left atrium. And the best way to think about it is a window between the pulmonary vein posteriorly and the SVC in front of it. So what you end up having is the posterior wall of the superior vena cava is deficient, and the anterior wall of the pulmonary vein is deficient, and therefore you end up with this gap and with these anomalous veins draining to the superior vena cava. So the techniques that we have to repair this were essentially surgical until about 10 years ago. And the surgical technique repairs are very well established. They're pretty safe with good results, but they are invasive and are associated with some long-term sequelae relating to the pulmonary veins and possible pulmonary vein obstruction. So one of the commonly used techniques is this two-patch technique. And essentially what the surgeon is doing is recreating the front wall of the pulmonary vein. So if you look here, the pulmonary vein is missing its front wall in the sinus venosus defect part over there, and they patch that, and then they expand the front wall of the SVC, so it's two patches, one on the pulmonary vein and one on the superior vena cava. And then the other technique is something called the Warden procedure. Now, the Warden procedure involves the surgeon transecting the superior vena cava, so they chop the superior vena cava off just above the pulmonary vein. They reconnect the superior vena cava to the right atrial appendage. Do I? Yes, thank you. So they chop the superior vena cava off. They reconnect it to the right atrial appendage, and then they have the flow behind that of the pulmonary vein to the left atrium. So again, well-established techniques. The Warden procedure, you will know, will be associated with superior vena caval obstruction. The two-patch technique may often give you pulmonary vein obstruction. So they're not perfect. And the exciting thing happened about 10 years ago, and I think that just before this publication was published, there was a presentation at the CSI meeting in Frankfurt of just an abstract of somebody who had already thought of how to do this. Yes, exactly. So I don't think he published his as a case report. So the publication that's always referred to is this one, which is the first actual printed publication of how to perform transcatheter treatment. And from there, I think it's just been very exciting advances. And the person who really took this forward in the world is a mentor and a professor at St. Thomas's Hospital in England called Eric Rosenthal. And he's really been the pioneer of collecting the data and making sure that this procedure is quite far-reaching. And this is from his paper and shows you how it works. If you are implanting a covered stent in the superior vena cava, the covered stent will then achieve all of the purposes of the surgery by doing the following. The covered stent will seal the connection here between the two atria. The covered stent will recreate the front wall of the pulmonary vein so that they are behind the stent, draining into the left atrium, and will recreate the SVC to RA junction. So by just implanting a covered stent in the SVC RA junction, you are able to correct this whole constellation of problems. And this, now 3D modeling and virtual reality is used quite a lot in this, in the understanding and the taking forward of this procedure. And this is again from Eric's paper showing you just how it all works. So if we're looking at the front in this B panel, that's the stent in place and you have SVC to RA connection in front. But if you flip the model round and look around the back, you can see that this catheter is inside the pulmonary vein, and you can see how there is a channel for the pulmonary vein behind the superior vena cava that hopefully should remain unobstructed behind where the stent is implanted. So to really get on top of this procedure, you have to understand what your objectives are. So yes, it's as simple as putting a covered stent in the superior vena cava, but you have to really know what you are trying to achieve. So if you focus on the top end of the stent, and I've included a picture here of the stent we most frequently use, which is the 10 zig covered CP stent. So 10 zig means it just has 10 zigzags, and the reason it has 10 zigzags is for it to be able to expand to larger diameters. The more widely available one, probably in Egypt and in the UK until quite recently, is the 8 zig. And the 8 zig will only take you up to 24 millimeters. So anything beyond 24 millimeters, the covering on the 8 zig will tear. So you needed a bigger stent to be able to actually seal the sizes of SVCs and SVC-RA junctions that we're dealing with. So the 10 zig stent has been the mainstay of treatment. And early on in the experience, they started using the shorter 10 zig stents and realized that they weren't good enough. So we are now increasingly using the 7 centimeter and the 8 centimeter 10 zig stents. Because what do we want to achieve? We want to achieve a seal at the top end. So in the superior vena cava, where the stent is going to land, we want to have a seal. But we often have pulmonary veins that are draining into the superior vena cava in that region. So you want to seal, but you also want to make sure you don't obstruct any high draining pulmonary veins. So your covered stent has to land underneath the high draining pulmonary veins. In the middle area, your concern now is about the redirection of the pulmonary veins that are going to be redirected. And in about a third of patients, we leave pulmonary veins undirected. So the really high apical ones, we leave them draining to the SVC, and that's not a problem because that is not a big shunt in itself. But the big veins in the middle, so the right upper and the right middle veins that are coming towards the SVC-RA junction, they need to be redirected. And we need to be able to judge whether or not we can safely put the stent and have space for the veins behind it or not. And we do that through a lot of balloon assessment and CT interrogation, and I'll show you some examples of how we do it. So understanding the pulmonary vein anatomy, is there a route for them to go from where they are into the left atrium through the sinus venosus defect? And then moving down to the bottom end of the stent, we need to achieve another seal. So if you look at the model here, you will see that this is the sinus venosus defect. Our stent has to extend all the way to the lower margin of that defect so that we can seal. Now, as you can appreciate, if that lower margin is quite deep into the right atrium, the size of the right atrium becomes quite large, and you start to enter into the region and territory where you have the right atrial appendage, so the sizes can become quite large. And this is becoming a limitation for us now, and we're already looking at making 12 zig stents. So the 10 zig stent can go up to 34 millimeters. If you are measuring diameters in that region of the lower end of the sinus venosus defect that's more than 34 millimeters, you may be wanting to look at bigger stents. Because if you expand the 10 zig beyond 34, the covering that's on it is going to tear and you won't be able to achieve a seal. So this is how you think about your procedure and planning it. I just wanted to talk to you a little bit about the approval process in the UK. I'm not sure whether there's a need for an approval process here, but the approval process wasn't just because we were doing a new procedure. The new procedure had to go through our hospital committee so that we could get that approved, but also because the 10 zig stents in 7 and 8 centimeters don't have a CE marking. So CE marking, like the FDA approval, approves the actual device. So these devices aren't approved for use. So we have to apply to a body in the UK so that we get approval. And usually when we're using something new, we would apply and just get approval on a case-by-case basis. But in this situation, we were planning to do a lot of cases. So what this body called the MHRA gave it, so they give us approval in 6-month blocks. So at any point in time, we don't have approval to do anything except for 6 months. So we do a certain number of cases in 6 months. We send back the data, they look at it, and then they reapprove. And we've been in that cycle until we get to the point where the stents are actually approved. We still are in, and we have to explain this to patients, so patients know that we're actually using something that hasn't been through big trials yet. But luckily, we are really smoothly moving ahead. But this has been in place in the UK from 2016. But as I'm showing you here, it just does take a lot of paperwork and a lot of work to get it done. So the pathway that the patients have to go through is every single patient has to have, of course, an echocardiogram to look at the right ventricular size, gated cardiac CT scans done by CT experts that are really kind of good at giving us the information that we need is important. CMR is important just for volume so that we can compare the pre and post, but the key thing for procedural planning is the CT. Everybody has to go through an MDT discussion in the presence of a surgeon, so we have to, as a team, agree that this is something that we're going to offer the patients, and therefore the support of your surgical colleagues is very important, because if you don't have the support of the surgeons, if you run into trouble, it's not going to be that great. But we have superb support from our surgical body. And then we create 3D models. I'll tell you how it worked. I think at the beginning of the program, we were creating printed 3D models for everybody. And then we moved on in our understanding of the anatomy, and we were creating 3D PDFs. So just like the pictures you were seeing, we weren't printing them, we were just creating 3D PDFs. And now we only create models for the complex cases. For the straightforward cases, we're not needing to create models anymore. We perform the procedure, and then on day 1, they get an echo, an ECG, and an X-ray. They go home on day 1 if they are well, and we see them in clinic in six weeks just with an echo. We repeat the CT in 3 months, and that's very important because there are two key things we're looking at. Are the pulmonary veins unobstructed, which is very important, and the other thing is, have we sealed the bottom end or not, because sometimes you can have a little residual leak at the bottom. And we repeat the CMR at 1 year to look for reduction in right ventricular volumes, and very pleasingly, every single patient who's had this procedure has almost had a near normal reduction in right ventricular volumes. I've put a list there of just what the procedural steps and the equipment is, just to highlight on the right how this is the equipment that we need for a straightforward case. If you have something that's a bit more complicated, we have to spend time thinking about a little bit more equipment. And every time I have a list of these patients, I will go through the equipment yourself. You can't rely on anybody else doing it. You go down, you sit down with the people who know your stock, you go through everything, you make sure you have the right sizes, because there is such a huge variation in possibilities that you really need to be prepared with all sorts of sizes, balloons, and different types of stents and things. But that's really the list of equipment that we have for every case. And this is the procedure. So the first part of the procedure, and we still do it like this in England. I think some countries in the world have moved a little bit away from doing balloon sizing and interrogation for every case, but we still do, because I really just kind of work with Eric Rosenthal, and this, he's quite keen that we continue to do this. So the first step of the procedure is to do a transeptal puncture and engage the pulmonary vein that you are going to be hoping to protect, so the one that you're very worried about that's close to the sinus venosus defect. You take a picture of that pulmonary vein, and then if there's another high vein like you can see in this picture over here, then you engage that as well. So this vein, we're not going to redirect it. This vein is going to be redirected. We have catheters in both. The next step is to put this long balloon, we use a balloon called Altosa balloon, inside the SVC to just check and see whether we have a number of things going on. We want to check and see that we have sealed at the bottom, so we do angiography to check if there's seal or not. TOE is key for us, so we can tell on TOE if we've achieved the seal at the bottom, and also to check whether or not this vein is unobstructed. We have catheters with pressures inside this pulmonary vein and in the left atrium to compare to make sure that we don't get obstruction. And this is the Doppler in the pulmonary vein when we have the balloon up, telling us that if we went up with a stent of this diameter, then we are unlikely to block the pulmonary vein. So once we're happy with that, then we go ahead and we perform the procedure. And the procedure is with a covered stent implant. And this first picture is I can't remember if this was 7 or 8, but this is probably a 7 centimeter covered stent in position. Now, we decided here to protect the pulmonary vein. So we put an Atlas balloon, a high pressure balloon in the pulmonary vein to protect it from being obstructed. And then the stent is in position. Lateral projections are very useful to get that orientation between the two. And once we've done that, then we deploy the stent. Now, the problem here is, as you can see, we measured this. This is less than 2 centimeters above the top end of the pulmonary vein. If you have less than 2 centimeters above the top end of the pulmonary vein, you will want to seal again with another stent on top. We check on the angiography, and there's a residual leak, so we still need to make the stent bigger. If I can show you this running picture. So you can still see that there is a leak there, and on TOE, which would show you the same again. And as I said, 2 centimeters above the pulmonary vein, if you don't have that much, then you will want to put what we call an anchoring stent. Now, in this situation, the anchoring stent has to be uncovered, because if you remember from the first image, there was a pulmonary vein draining up here. So this is an uncovered stent. And then we confirm that our pulmonary vein that is at the covering is unobstructed, and you can see it now going into the left atrium. There's still a little residual leak there. And then finally, we had a residual leak, so we do a balloon dilatation of the lower end to flare the lower end to make sure that we seal. And that's the usual procedure. I'd say it is relatively rare for us to just use one stent in this situation, but I'll show you another type of stent that's available where we can use just the one stent. And so this is really quite typical of the procedures that we do. This is an example where we have a high apical. I mean, I think the data suggests that a third of patients have these high apical veins. In my experience, I think at least half of them. They are very common. And so this high apical right upper pulmonary vein draining. And I just wanted to show you this because in the last patient, we put one stent and then the second, but you can actually put both stents onto one balloon. So I think if you're planning to perform this procedure here and you don't have the very long stents, overlapping 5 and 6. So this is a 6 and a 5 overlapped together, but you need the long balloon. So you put them both on the long balloon together and then you deploy them simultaneously. But you just have to be conscious of where that level is. And it's nice here because you can actually see the top level very easily, and you can keep it away from the vein. So that's the inner balloon inflated, and then the outer balloon then is fully inflated. We flared the bottom end with a balloon, and you can see, not on this image, but the apical vein, you can actually just about see it there, yes. So the apical vein with the balloon inflated is still unobstructed, so that's fine. So that's just an example of putting two stents on one balloon. So where are we with this procedure? I mean, I think it's far from perfect simply because there's so much variation in anatomy and there is complex kind of anatomical considerations and we don't have the equipment that tailors to all of this. One of the stents that's quite nice is this Optimus stent that has been designed now with a top end that's uncovered and a bottom end that's covered, so it kind of replicates what we do with two stents, although you could argue whether that's better or just actually putting the two in the position that you want them to be in. Another exciting advance is this VB stent by Joseph Vetukatel, who's in the USA. It's a self-expanding stent that tailors to the anatomy, expands at the bottom end, and we're on our way to starting to use the 12-zig. So there's a lot that still has to happen with the anatomical side of things and the stents that we have, and we don't have much long-term data. And this is an example from Sébastien in France using the Optimus stent, so the one with a covering and an uncovering, and you can see that the top end with the uncovered section has left that vein patent, and these are the other veins that are going to be redirected nicely. So lots of exciting stuff. So the final few slides just are about the worldwide experience, and these are from Eric Rosenthal. So as I said, this procedure has been described from 2014. I don't know where that 2011 came from, but maybe I think maybe the publication was 2014. Maybe it was happened before. So 381 patients worldwide so far, and the high accessory pulmonary vein only in 63. But as I said, in my experience, it's a lot more common than that. And 3 patients have died from things that are unrelated completely to this procedure. Balloon expandable stents in the vast majority, and it's very much the 10-zig CP stents that we're using. That's the one that's worldwide use. But you can see that the Optimus stent is gaining ground and becoming something that's used. The VB stent that is interesting has only been used about 5 times. So a lot of people using it. It's important to recognize what the complications are. Stent embolization in the early experience was relatively more common. Now I think the use of anchoring stents and the use of longer stents has allowed us to reduce the chances of that happening. In our UK experience, we've only had one stent embolization. Maybe sinus node dysfunction. In our experience, that hasn't been a problem. Very early in the experience, pericardial effusions from the transeptal puncture, and only one in the actually it was in Ireland, one pulmonary vein obstruction, but worldwide. So that's just the one in the whole world, narrowing in about 8, and minor problems like little leaks. We've noticed this. So in one of our patients, we had arm neuropraxia because you do this with the arms up, and they're very lengthy procedures, and patients wake up with the brachial plexus being a bit stunned. It's very scary for the patients. In every patient worldwide that it's happened, it has resolved completely. And that's just a map of really what's happening worldwide. The largest number is in Europe, but the largest number in any individual country is in India. And Eric has very kindly really put all this together, and there's a publication coming from this data in the very near future. So that's really it, and that was just a final slide to thank the team in my trust, and also in Guy's and St. Thomas's, who we work closely with. Thank you, and sorry if we're running. Yeah.
We can use shorter stents, and the right atrium will not be that big.
Yeah,
so
I think
maybe.
Worldwide there's a bit of concern about using in children.
Yeah.
India have used it in children.
Yeah.
And if you want to talk to someone who's done quite a lot in children, I most certainly can kind of put, I think you probably know him. Yes. Sorry?
Who's doing that?
In India, Siva Kumar. Yeah, so I'm sure you know.
Yeah,
so he's done a lot of children. I mean, our concern about doing it in children is about growth. And when, so the stent won't grow. It's like if you stent an SVC in a child, they often come to me and then I have to, so it's about growth. And so it's not about sheath size, it's not about any of that. I think it's just about growth of the stent with them. But maybe if we look at the Indian experience, you may want to. And if anything, we are actually, if my pediatric cardiology colleagues have a child who's 13, we just say wait. Because usually they're fine to wait. So we wait until they're about 16, 18 and do it.
Thank you very much.
دكتورة رضوى, thank you very much. أنا عايزة أسألك, you have some inferior, right inferior pulmonary vein anomalously connected. Did you see this anomaly?
Yeah, we see them, but we
you
have
some cases?
No. And I don't know if there are any public. I think the problem is the hepatic veins. I think we're starting to think about that possibility. I think you'll have a couple of challenges. If the hepatic veins usually come, you don't have enough length to anchor inferiorly because the hepatic veins will be in the way. You have to cover.
But
so
if it is connected near to the junction with severe venicular right atrium, can be done.
Oh, right lower pulmonary vein to. I've never seen a right lower to the junction. Of course, yeah. If you had a right lower to the SVC-RA junction, yes, of course, it's the same principle. But if you have right lower to IVC, which is the more common scenario, I think people are excited about maybe doing it, but not yet, and I don't think so.
What is your absolute contraindication?
Absolute contraindication.
Don't just surgery, will not consider transplant.
I think that's a tricky one because I don't think it's so relative depending on the patient in front of you. I've recently sent a young woman to surgery because the high right upper and the middle were coming in so close, and I think there was a very good chance that we wouldn't be able to preserve that vein and redirect, and so we thought she'd get a better result from surgery. But if that same patient was not in her 30s and she was in her 70s, we would have performed the procedure. So I think you really need to put everything together about what's best for the patient. I think potentially an absolute contraindication may be if they need surgery for something else. But increasingly, even if they have severe tricuspid regurgitation, we're still thinking we'll do it. And if the TR is still bad, we will do a TriClip. So it's such an evolving field. I can't think that there is anybody where I would say absolutely not, except the ones with very large ceiling at the bottom end where we think we're going to get a lot of leak.
And when would you start the procedure and then decide that this is not going to enter the afterwards?
Oh yeah, we've done that quite a lot really, if the pulmonary veins are going to be obstructed. So the key thing is you will do more harm if you block the pulmonary veins. So if we balloon test and we can't achieve a seal without blocking the pulmonary vein in the procedure, we stop. And we've done that twice, where we've just stopped and sent them to surgery. لو حضرتك تفكري في المساحة دي هي it's a shared space. It's a shared space where the superior vena cava has its space and the pulmonary vein has its space. If you ما فيش distance هي it's You have to seal. If you can seal والpulmonary vein مش لاحظي ان احنا لما بنعمل pulmonary vein protection we protect the pulmonary vein with a high pressure balloon. So the Atlas balloon in the pulmonary vein will be at 14 atmospheres. The CP stent when it's going up, it's going up at 5 atmospheres. So you will not impinge on. وحتى if you impinge, you can put a bigger Atlas balloon in and then you can bring the stent back. But you will end up with a little residual leak.
I think understanding this is having the mindset that the pulmonary veins are posterior.
Yes, yeah.
So unless you understand that they are posterior,
Yeah.
and then you want to figure out the.
And that's why the lateral,
This is not linked, it is,
it's anteroposterior. It's the space anteroposterior. لازم distance to seal. لكن space for the pulmonary vein is about the anteroposterior with the length of how big the junction. Pulmonary vein اللي بيjoin the SVC with a very big length, that's good. لأنه مش ضيق من فوق لتحت. It's
what is the best criteria?
the best case to start with is somebody that does not have an apical vein, because what you can do then is put the longest stent you have and put it as high up as you can. So that's a really good thing. Somebody without a very big SVC RA junction and someone with a big pulmonary vein. So
What
there,
about the caudal insertion in ESTD?
the caudal extension is a bad thing, because if it extends caudally, you enter right atrial appendage and right atrial body, فمش هيبقى عندك space to seal. The less caudal extension, the better. From the ideal cases, يبقى superior sinus venosus defect مش نازل قوي into the right atrium, والpulmonary vein كبير, وفي كتير. بس as you do more, the more difficult ones will start to come your way. فحاليا احنا
My question is, if you see a patient with pulmonary vein obstruction on full obstruction, what then would you
So we have had none. Ireland, our colleagues in Ireland had one complete pulmonary vein obstruction, and the patient was so symptomatic they had to have a lobectomy. It was bad. So they had to have thoracoscopic lobectomy because there was hemoptysis and things. I think in the data that I showed you that Eric Rosenthal has collected from the whole world, there have been patients with pulmonary vein narrowing where they have gone back in and tried to balloon them, not stent them, I think just balloon dilatation of pulmonary vein narrowing. We've had cases where we were worried about the pulmonary vein and had to upsize the protective balloon one size so that we could just make it a little bit broader, but that's it. I think when Eric started his cases, the first few he was doing retrograde, and it was really a bit of a fiddle. So now what we do the first step is transeptal puncture, engage the pulmonary vein. You keep a catheter there throughout the procedure, even if you're not going to protect the pulmonary vein. If you're going to protect the pulmonary vein, you upgrade to a stiff wire and you put your Atlas balloon in. Yeah.
Thank you. Beautiful presentation. Pardon my ignorance, I'm not in interventions. Going back to the basics. For each case, you do CMR and gated CT.
Yes.
And this is to get the volume and the anatomy. Right?
Yes.
So by definition, the sinus venosus should have an anomalous right up.
Yes.
Okay. So why are we so worried about one vein being blocked when we have 3 others? Okay.
I mean, I think that's a really good question, because maybe it will be okay, but I think we are, if we have techniques where we can preserve that vein, we think that that's better. I suspect that those, we call them apical right upper pulmonary veins, so tiny little branches that just drain the apex of the right lung. I don't think it's a problem, but certainly we don't go out. Oh, no, this one was blocked. I think it was it wasn't at an apical right upper. I think it was the confluence that it was the main. So you have to think there are 2 key veins here. The veins that are at the defect, they're important. The veins that are higher, they're not that important, but we try to preserve them.
I want to talk about directing it. So what do you mean by that? You put the stent, you put the balloon, and how are you directing? Because it's opening inside the space.
You're directing it because you have the covered stent creates a front wall to the pulmonary vein.
Okay, so
so it's behind it, and the sinus venosus defect is still there. So it exists, the space for it exists, and the channel into the left atrium is your defect.
Directing is channeling.
It's channeling. It's exactly that.
When you talk about doing channeling, so you prefer an uncovered stent.
No, you have the actual procedure has to be with a
Cover,
covered stent.
because you want to block.
Yes.
But for the redirection or rechanneling, you prefer non-covered, right?
No, the covered stent is what actually performs the channeling.
The ones that are going to be half off.
Yeah, so the top one is just for anchoring. The top one is just so that we don't, because if you don't have enough length above the vein, it will drop into the right atrium, it will embolize. So that's an anchoring stent for stability.
Covered one.
The top one is uncovered.
Uncovered.
Yeah.
And the covered is to close the hole.
Yes, the covered is to close the hole.
And redirect at the same time.
Yeah.
And redirect. Thank you very much for that.
السلام عليكم. الدكتورة سوزان. It's my great pleasure to ask Dr. Suzanne to present her talk about mitral valve prolapse, disjunction and arrhythmias. أهلا وسهلا. ازيك؟ اتفضلي.
السلام عليكم ورحمة الله وبركاته. فرصة سعيدة الحمد لله إن احنا نبقى جميعا مع بعض هنا، وكل عام وحضراتكم بخير، و thanks for the organizing committee for this beautiful meeting of all pediatric cardiologists. My talk about a specific area, mitral valve prolapse and arrhythmia, and the new concept of mitral valve disjunction with this arrhythmia. Normal mitral valve apparatus consists of the annulus, the two leaflets, the scallop, and the papillary muscle. The annulus is saddle-shaped fibrous structure at the intersection of the left atrium and left ventricle. So usually in 3D echo, they usually describe that the mitral annulus is saddle-shaped like, and in repair edge-to-edge transcaster, they depend on this. So there is usually intersection between the left atrium and left ventricle and the mitral valve annulus in the middle. The anterior annulus is continuous with the aortic valve and is a part of fibrous skeleton of the heart. Fibrous skeleton, the aorta in the middle, central, and both leaflets, mitral and tricuspid, coming from it. That is the central fibrous body of the heart. That's diagram, and that is MRI for normal and continuity between the left atrium and left ventricle. Mitral valve prolapse is most frequent, with a prevalence of 0.6 to 2.4%. Reports on the outcome shows that complications are minor and it is benign finding. However, some complications have sudden cardiac death. The annual rate of sudden cardiac death is about 0.2 to 0.4% and is approximately twice as high as in general population. So this makes a lot of research about this item, arrhythmia in mitral valve prolapse. Arrhythmia in mitral valve prolapse recognize two components, the substrate, which is regional myocardial hypertrophy and fibrosis, and the trigger, which is mechanical stretch making premature beats because of morpho-functional abnormality of the valve. So two components, not only the morphology. That is the anatomy of the mitral valve. That's a case of normal mitral valve, a case of mitral valve prolapse, and a case of mitral valve disjunction. That is the yellow segment between the left atrium and left ventricle, which is the distance separating left atrial wall from left ventricular wall just beneath the mitral annulus. So there is no continuity. There is separation between the atrial tissue and ventricular tissue, and this area usually is fibrotic, no myocardium there, and that is the trigger of arrhythmia in cases of mitral valve disjunction. Not only disjunction, there is triggers for arrhythmia and sudden cardiac death in mitral valve prolapse. Factors regarding the valve, regarding the left ventricle, regarding the autonomic nervous system, and the arrhythmia. All of this, like leaflet morphology, annulus, disjunction, one of them, and not all of them, mitral hypermobility, excessive in the left ventricle, excessive hypertrophy, presence of fibrosis, connective tissue disorder, and ischemia, and so on. Or autonomic nervous system and presence of long QT or cardiomyopathy, And also, the new substrate is genetics in mitral valve prolapse. A lot of genes are responsible for this arrhythmia, whatever there is disjunction or not. Biomechanics and mechanics of mitral valve prolapse and disjunction depends on the curling. Curling means presence of abnormal motion in the area of disjunction, which makes stress on the papillary muscle and chorditendine and Purkinje fibers and leads to arrhythmia. That is diagram how arrhythmia develop in cases of mitral valve prolapse and what we look for, and begin the investigation, begin with the symptoms, and then one step by step go for ECG, Holter, echo, MRI. Speckle tracking is very important as well, as there is what we call dispersion in the left ventricular myocardium could be detected early by speckle tracking, which is also responsible for arrhythmia. So we begin with ECG. There is T-wave inversion or frequent PVCs or so on, and look for echo. And if we need MRI, go for MRI. And then look also for the symptoms, put it in the first, and look for the post-family history, very important. And another test, which is fluorohydroxy uptake, like in cases of SPECT, to detect ischemia and fibrosis. So to look for all of this, we summarize the presence of mitral valve prolapse into there is arrhythmia or not. If there is no, shall we make this slide in by the end? But this tell us that arrhythmia in ECG or Holter or symptoms of syncope or previous arrest is the leading for all this investigation, and that absence of this arrhythmia may lead us to a lot of investigation, but we are in a benign situation. What about disjunction? Disjunction refers at, as we said, atrial displacement, and it has described around 20 years ago. It is seldom recognized without attention for this area. So please, we need to make attention for all cases of mitral valve prolapse to look for this disjunction. 5 to 10% of patients develop mitral regurg, require surgery, and ventricular arrhythmia-related sudden cardiac death could occur in up to 1 to 2%. That is by definition, and that is how to look for. That is the anatomical, and that is what you look for. If you had disjunction more than 5 millimeter, you are in a case of disjunction with prolapse, and you should go for ECG, Holter. Ask carefully about the symptoms of the patient, and if there is symptoms and the Holter shows types of arrhythmia, whatever SVT or frequent PVCs, go for Holter. But not all the cases go for MRI. Not all the cases need MRI. So that is, I asked me this question when I'm making this presentation. All cases need MRI, and I found it in the previous diagram, which I put it in the end. Cardiac MRI needed if there is symptoms and disjunction and arrhythmia in ECG or Holter, because it actually makes this disjunction clear. You can measure it carefully. If it is more than 5, you are in a case of disjunction, and it can assess if there is myocardial fibrosis in this area, infralateral free wall or not. In the presence of fibrosis with arrhythmia, that is dangerous situation, and we go for EPS study and may need ICT. That is MRI picture for cases of disjunction. That is the blue, the black spots on the left ventricle with the arrow, which is the areas of fibrosis. And we have cases, I have cases had MRI and there is fibrosis, others no fibrosis, and so on. And that is on here in the above segment, the arrow, and the histology shows that there is the black stent, which is the areas of fibrosis in histopathology. And that is another case. That's a case of MRI. That's one of our patients who will show it. And the MRI shows disjunction clear. Where is the arrow points? It is the area of bulge between the mitral, between the left atrium and left ventricle at the level of the annulus, without fibrosis Holter normal and no. Okay, تمام. Example of a case of disjunction on echo. What is the types of this disjunction? There is a lot of types, either with mitral valve prolapse, which is myxomatous degeneration, or without. I mean that there is cases of mitral disjunction without mitral prolapse. And that is the saddle-shaped annulus of the mitral valve. And they divide them another division, another classification according to the annulus, mobility and the separation, type 1, type 2, type 3. In all cases, when the disjunction is more than 5 millimeter, it is significant. Less than this, no. And that is paper. The story begins retrogradely. The cases who had sudden cardiac death and had before investigation like MRI, they make analysis for them. And which one of those who had cardiac death had mitral valve prolapse, and they revise the MRI, which one had mitral valve disjunction, and so the story begins to look for this disjunction and may book attention for this. Mechanism of arrhythmia. Why arrhythmia happens in this? Presence of this discontinuity leads to lack of coupling between the left atrium and left ventricle, and this lack of coupling leads to tethering on the mitral annulus, loss of the usual saddle-shaped morphology, which is very important, hypermobility of the annulus in systole and diastole. So some persons look for disjunction only in diastole. It could be pseudo-disjunction. You should look for it in diastole and systole, in late systole, and measure it, not only in diastole. Now, a case of mitral valve prolapse with unexplained cardiac arrhythmia. What to do? Evaluate MAD if it is present. What we do, and if it is not present. If it is present and more than 5 millimeter, go for MRI. If MRI is positive, evaluate the risk of arrhythmia and ask EPS to study if there is need for ICD or not. If it is negative, evaluate the other causes that make risk for arrhythmia in this patient, the LV function and so on. That's the example of a case of myxomatous degeneration, and the arrow points to the MAD here, the separation between the mitral annulus and here on MRI, look for this curling abnormal motion at the area of the annulus, and another case with MRI and as well regional wall motion in the posterior lateral wall. So MRI give information not only about the disjunction, but also about the wall motion and the fibrosis. That is, that is one of my patients. Accidentally, she had chemotherapy and coming for echo to do an echo before completion of chemotherapy. And actually, she had mitral valve prolapse. I do ECG normal, echo normal, Holter normal, no symptoms, age 45. Actually, I didn't go for MRI. On the other hand, young girl having mitral valve disjunction with frequent ectopic beats, and we asked for MRI. That is lady around 32 years old. There is fibrosis. This case was Dr. Ghalia. I asked and fibrosis in the MRI. She is going for EPS because no control for this. BVCs, but a lot of drugs, beta blocker, flecainide, and so on. Mitral valve prolapse and MAD could happen in a special group of patients, not only as a separate anomaly. In Marfan's, Loeys-Dietz syndrome, aortic stenosis could happen with tricuspid valve disjunction as well. And there is reported cases of MAD with Hockham, and I have a case of MAD with coarctation. All right? And that is not written. So we look for this literature. Mitral disjunction is associated with adverse outcome in Marfan's, Loeys-Dietz, and there is tricuspid annular disjunction, which is not risky, and no risk of arrhythmia in tricuspid valve disjunction. A lot of studies done about it. It could be associated with the mitral, but not risky. Okay? That is ECG for one of my patients, normal. Although she had attack of palpitation and diagnosed as SVT, in a hospital before she comes to me, and the echo showed mitral valve prolapse. الايكو بقى مش هيشتغل ليه. And mitral disjunction. معرفش الفيديو بصراحة مش شغال ليه. If we look for this area between the mitral and the left atrium and left ventricle. معلش الفيديوهات كانت شغالة تحت يعني. The arch, there is amputation of the arch, no flow coming from the arch to the descending aorta, and only she had mitral prolapse, myxomatous degeneration, elongated chordae, mitral disjunction as well, and history of palpitation, and damped flow in the descending aorta, and there is the disjunction. Sorry for this videos بصراحة. And she had MRI, mitral valve disjunction, with prolapse, and also she had critical interrupted aortic arch. Actually, a bicuspid aorta as well. So it is with bicuspid aorta, not Marfan's. Critical segment of coarctation with collateral supplying, no significant left ventricular hypertrophy. And actually, my dear Professor Dr. May did very, very nice stenting for this case. And she is very good now. She is doing a normal life. Just follow up for the mitral valve prolapse. It was nearly interrupted. After the procedure, she is going well. I follow up her every 6 months, and there was associated coarctation. She had attacks of arrhythmia, not with me, but diagnosed as SVT, and took isopten in a hospital a few months before I evaluate her. If there is MAD without prolapse, yes. Patient with MAD mean mitral valve disjunction without mitral valve prolapse. Presented with frequent premature ventricular contraction, 1/3 had ventricular arrhythmia, and 1/10 had severe arrhythmia. A total 22 patients did not have prolapse. So MAD was detected in a large cases of mitral annulus circumference with considerable variation. And actually there is a study about MRI in cases of mitral valve prolapse with MAD and cases of MAD only. The incidence of arrhythmia was, this is the only one study I have, more in MAD without prolapse. So MAD itself carries a risk. Here, this is the study. Look for that is MRI. Here is the case. Looking if there is a prolapse or not, and looking for the and there was high incidence in cases of arrhythmia. Management. How to manage cases of mitral valve prolapse with disjunction? Like cases of mitral valve prolapse, but the risk is higher in presence of disjunction if there is arrhythmia, medical treatment. If there is no fibrosis and no need for EPS or ICD, medical treatment, beta blocker, flecainide. But we say that surgery is recommended more and earlier in cases of mitral valve prolapse with MAD if there is any incidence of arrhythmia, even if left ventricular function is good or mitral regurg is not so severe. How to intervene? Surgery or TEE, edge-to-edge transcaster repair for the mitral valve. Actually, surgery carries better prognosis because in surgery, the surgeon could make re-anastomosis or make another communication between the myocardium and the left atrium and make the plication of this area of disjunction. Follow-up of such cases after surgery found that the incidence of arrhythmia less on Holter study, and the symptoms is better and the prognosis is better. Even better than the cases that has transcaster edge-to-edge for mitral valve prolapse. نعم خلصنا خلاص. جينيتكس الميترال فالف برولابس وده 2024 ان احنا عندنا جينز كتيره جدا وبوزيتيف فاميلي هيستوري اوف سادن كاردياك ديس الميترال فالف برولابس. لازم ندخل على جينيتكس كلها زي كروموسوم 13 وترانس جروس فاكتور وهكذا. بنبص للميترال فالف برولابس از ا كومبلكس انتيتي ما بين الميترال والليفت اتريوم والليفت فانتركل، والريسك اسسمنت بيعتمد على حاجات كتير. هقول الدياجرام بقى اللي هو ده. بنقول انه لو عندي mitral valve prolapse patient بنقسمه حسب الهولتر وحسب الجريزو. مفيش اريثميا ماشي اهلا وسهلا، في اريثميا وفي فيتاك وعملنا اسسمنت للفيتاك يا اما مثلا بشوف الميترال فالف ده النيد فور سيرجري تمام ريبير ولا هدخل على اي بي اس بس. يبقى الكي بتاعي هو الاريزميا والهولتر والاي سي جي. لكن وات ايفر انا عندي تي ويف انفيرجن، انا عندي مال، انا عندي ميترال فالف كولابس، وما عنديش نو فريكوانت ابيسود او فيو فريكوانت ابيسود، فريكوانت مونيتور. عندي فريكوانت ابيسود اوف بي بي سيز او بريماتور بيتس، لازم اعمل periodic monitoring بهولتر ولازم اعمل MRI. If not, no MRI and no need for it. So still the symptoms, the Holter are key management for sudden death or arrhythmia in mitral valve prolapse. Now, implantation of cardiovascular fibrillator and so on. Thanks a lot.
Thanks a lot, Dr. Suzanne.
Acute arrhythmia is the main presentation of malaria. We usually, according to the guidelines, we usually refer to MR because in grade 1 or type 1 malaria, there will be no displacement at all, and that's the time the patient will present with arrhythmia. So to detect the extent of fibrosis, the presence and extent of fibrosis, we have to have MRI for all cases in spite of your concern about that. MAP is a very, very disaster condition. And we have a mitral valve collapse commonly, especially in females, and will not leave a chance for those patients to be managed as single mitral valve. Please, we need to deliver a space between the posterior leaf and the infralateral part of the left ventricle to have suspected ECG, Holter, and then MRI. It is a very, very nice maneuver or tool for diagnosis of single.
هو بصراحه الكونسيبت ده كان بتاع كله، كنت بسال نفسي اعمله ولا لا، بس في الجايد لاين الاخيره دي سبتمبر 2023 لقيت الدايجرام ده، فانا يعني اعتمدت على اخر حاجه قريتها. بس طبعا راي حضرتك مهم جدا لان ممكن البرزنتيشن الوحيد يبقى صعب ديس، بس الهيستوري والهولتر والاي سي جي لو ما فيش يعني الحاله اللي كانت تاخد كيموثيرابي دي والديسجنكشن اكتر حاله شفتها 9 مللي، بس ما قلقتهاش عندها مايلد مايترال ريجيج مفيش سيمبتوم، الهولتر كويس، الاي سي جي كويس. قلت لها لو في اي سيمبتومز هنعمل، ما فيش عملت لها فولو اب بريودك فولو اب. فطبعا راي حضرتك طبعا.
Thanks a lot, Dr. Suzanne, for this marvelous presentation. So it's my pleasure to introduce Dr. Heba Kamel, Assistant Professor of Cardiology at Ain Shams University. She's my dear senior and she's a pioneer in fetal cardiac medicine. She'll present fetal arrhythmias. Fadlan.
Good morning. Today we're going to speak on an interesting and not a usual topic, which is fetal arrhythmias. So, as we know, the fetal conduction system is fully matured by 15 or 16 weeks. And that fetal arrhythmias are diagnosed in approximately 1% of all fetuses, and maybe 49% of the cases for referral for fetal echo are due to fetal arrhythmias. The most common fetal rhythm abnormality in pregnancy are premature atrial contractions. So we have many indications to evaluate the fetal rhythm, but mainly if we have sustained fetal heart rate above 100 beats per minute or below, above 180 beats per minute or below 100 beats per minute. If we have irregular, frequent heartbeats, and if we have hydrops fetalis, we have to do evaluation for the fetal heart rate. And in case of fetal arrhythmias, we have to refer the patient for the cardio-obstetric team. So how do we diagnose or evaluate fetal arrhythmias? First of all, we see the heart rate. Then we evaluate the rhythm, and we have to exclude any structural or functional abnormality in the heart. We use the echo. We use 2D, M-mode, pulse wave, and other modalities. 2D will help us to see the heartbeats, if it's fast, if it's slow, if we have hydrops, if we have any structural abnormality. Then we assess the rate and rhythm using the M-mode and pulse wave Doppler. M-mode is the earliest technique. We have the cursor directed across the atrial and ventricular walls simultaneously, recording both at the same time. And we can use pulse wave Doppler also by our cursors at the simultaneous LVAT mitral valve or simultaneous SVC aorta, which is also going to be important to measure the AV and VA intervals, what's going to help us in the management of supraventricular tachycardias. So we have different rhythm disorders, including irregular heartbeats, tachyarrhythmias, or bradyarrhythmias. Let's begin with the irregular heartbeats. The irregular heartbeats are mainly fetal ectopies. They have many causes, including idiopathic myocarditis, tumors, maternal stimulants. Mainly, there are atrial premature beats. These are the more common. They are mainly benign, hemodynamically insignificant, but in 1% they may progress to supraventricular tachycardia. So echocardiography and serial follow-up is very important to discover if we have runs of non-sustained VT that can cause later on hydrops fetalis. It has two types. As we see here, we have the conducted type and the non-conducted type. The conducted is that the atrial and the ectopic beat are conducted to the ventricle, but the non-conducted type, the ectopic beat is not conducted. And we have the ventricular premature beats. The ventricular premature beats are less common. They are about 5% in the atrial ectopies, or the fetal ectopies. As we said, they don't need a specific medical management, just serial follow-up to diagnose if we have any runs of SVT that can cause hydrops fetalis. What about fetal tachyarrhythmias? Fetal tachyarrhythmia are diagnosed with pathological fetal tachycardia with heart rates maybe reaching up to 300 beats per minute. They have many types, as we see here, with sinus tachycardia, supras, flutters, ventricular tachycardias, and other types. So how can we differentiate between the different types? We do assessment by M-mode to see the AV relation. If we have a one-to-one AV relation, then we have a supraventricular tachycardia. We have here to measure the VA interval. If we have a short VA interval, then we have a re-entry tachycardia, like the AVRT or AVNRT. If we have a long VA tachycardia, then we'll have the atrial tachycardias. If we have an AV relation more than one, then we'll have flutter or fibrillation. If the AV relation is less than one, then we'll be having most probably a ventricular tachycardia. The most common type of fetal tachyarrhythmias are supraventricular followed by flutter. They can have very common associations with Epstein anomaly, common AV canal, hypoplastic left heart, intracardiac tumors. So as we said, we have a re-entry tachycardia. And it's important to measure the VA interval and AV interval. And it's considered 60% of the SVT. And we have a one-to-one AV relation, as we said. Or we can have an atrial flutter, which is a micro-re-entry tachycardia in the atria, which is considered 30% of the supraventricular tachycardia with a one-to-one, with the AV relation more than one-to-one. Again, it's important to measure the VA interval. It can be short or can long, but it will help us in the measurement of the supraventricular tachycardia. Because if we have a short VA, we can manage with a single drug as digoxin, or we can begin with digoxin. If we have a long VA, we'll need most probably a combination therapy, or we need a second-line therapy. Ventricular tachycardias can happen either with idiopathic arrhythmia syndrome and long QT syndrome, or it can happen due to other causes as heart blocks, tumors, myocarditis. It's extremely rare, yet it can cause hydrops and sudden cardiac death. And the management will include intravenous magnesium, oral propranolol, mexilitine, or lidocaine. What about intervention in fetal tachycardia? So we have a fetus with tachycardia. What shall we do? We have several options. We can deliver the baby. We can do transplacental administration of maternal drugs. We can do direct administration of fetal drugs in the fetal circulation, or observation. It will depend on the gestational age, the hydrops, and the type of arrhythmia. So for example, if we have a fetus with fetal tachycardia and we have a gestational age above 35 weeks, we can deliver the baby. If we have below 35 weeks, we have to see if there are hydrops or not. If If we have hydrops, then we need to begin with flecainide, sotalol, direct fetal therapy. If we don't have hydrops, we can begin with digoxin and add-on. Always remember this, if you're going to give the mother medication, you have to follow her up meticulously. You have to do her baseline ECG, renal function, thyroid profile, electrolytes, monitor the serum levels of the medication, and monitor the fetal well-being. As regard the delivery consideration, deliver the baby as close to term as possible in a center with pediatric cardiology facility and elective C-section if the fetus is compromised. According to the recent Heart Rhythm Society consensus in 2023, if you have fetal atrial tachyarrhythmia and it's intermittent, then you can just follow up the baby. If you have an incessant tachyarrhythmia and the baby is close to term, deliver the baby. If not, then you can begin with flecainide, sotalol, combination with digoxin or single therapy and follow up the patient, or you can do direct fetal therapy if it's not succeeding. If you have ventricular tachyarrhythmia, but not with inherited arrhythmia syndrome, it will depend. If you're close to term, deliver the baby. If not, then you can give IV magnesium, mixilitine, lidocaine. It's very important to follow up the patient with cardio-obstetric team, and it's very, very important to follow up the baby with fetal echo meticulously. Many papers published showed the role of flecainide and sotalol in the treatment of fetal tachyarrhythmias. But a paper recently in 2022 showed the superiority of flecainide alone or in combination with digoxin in the management of fetal tachyarrhythmias. What about fetal bradyarrhythmias? Fetal bradyarrhythmia is a heart rate below 110 or 100. It can be isolated with maternal autoimmune disease, typically presenting between 16 to 28 weeks. The mother will have anti-Ro and anti-LAR antibodies. Or it can be with congenital heart disease and will show early presentation. How can we differentiate between the different types? Again, M mode and AV relation. If we have a 1-to-1 AV relation, then we have sinus bradycardia. If we have a 2-to-1 AV relation, then we have to measure the AA interval. If it's varying, then the bradycardia is due to blocked premature. If it's constant, then it's a second-degree heart block. If we have a complete AV dissociation, then it's complete heart block. Sinus bradycardia is mainly due to external factors. Maternal compression of the abdomen, cord compression, placental insufficiency, maybe due to sinus node dysfunction. The 2-to-1 AV relation will be, as we said, due to non-conducted premature or second-degree heart block. So we have to measure the AA interval. If it's varying, then it's due to blocked premature. And if it's not, and it's constant, then it's a second-degree heart block. If we have a second-degree heart block, you have to exclude autoimmune, maternal autoimmune disease. And if we don't have, you have to suspect long QT syndrome. Long QT syndrome has many presentations, including bradycardia with heart block. So you have to measure the IVRT. If it's prolonged, you suspect long QT syndrome. If we have a complete dissociation, then it's complete heart block. This is a differentiation between the second and third degree. As we see in the first picture, there's a complete AV dissociation, but the second picture, you have a regular constant AA. What about the indicators for poor prognosis? If you have actually an early presentation before 20 weeks, if you have hydrops, impaired functions, ventricular rate below 50, these are poor prognosis for outcome. If I have a fetus with fetal bradyarrhythmia, first of all, you have to exclude maternal autoimmune disease. If you have a low-risk patient with heart rate above 55, you can just observe. Below 55, you can begin beta agonist. If you have a high-risk patient, you can give steroids with beta agonist. Also, in another cases of complete heart block with hydrops, you can begin IVIG. Again, you have to consider your patient. Is his term, preterm, is there hydrops or not? You can begin steroids, but it has a weak evidence. A recent paper published in 2020 showed the effect of hydroxychloroquine to prevent the recurrence of congenital heart block in the mothers with positive anti-Ro and anti-LAR, and it showed a decreased recurrence rate by more than 50%. Again, according to the recent consensus, if you have fetal bradycardia, first of all, exclude autoimmune disease, maternal autoimmune disease. If you have heart block, then you have to do serial echo to exclude hydrops, impairment of function, fetal compromise. You have to be followed up by a cardio-obstetric team, and you have to exclude idiopathic arrhythmia syndrome. And if you suspect or confirm idiopathic arrhythmia syndrome, then you have to have a baseline fetal heart rate and follow it up. You have to avoid any medication that can prolong the corrected QT for the mother and the fetus. And you have to, if we have a presentation with torsadopa, you can give IV magnesium loading, then maintenance. Again, any mother, you have to exclude, with a mother with autoimmune, you have to exclude the antibodies. And fetal echo here will not be just for confirming the arrhythmia, but also will have to exclude arrhythmia-induced cardiomyopathy and monitor the fetal cardiovascular system by serial assessment using the CVP score. So finally, fetal arrhythmia can be accurately identified by fetal echo. Identifying the mechanism is very helpful in the management. Sustained fetal arrhythmia can lead to hydrops, dysfunction, maybe death, especially in the fetal bradyarrhythmias. Treatment of the fetal arrhythmias generally involved either maternal systemic administration of antiarrhythmic or direct fetal intramuscular injection or intraperitoneal injection of antiarrhythmics. Recent studies and consensus, including some randomized trials, have shed the light on pharmacological options in the management of tachyarrhythmias, especially the flecainide and sotalol, and provide further evidence-based treatment strategies. Thank you.